Hello everyone, hello and welcome to aidsmapLIVE special, HIV and COVID-19. I'm thrilled to be here, virtually at least, with a very distinguished panel that I'll introduce to you now. First of all, joining us all the way from South Africa is Dr. Sindi van Zyl from Doctors for Health in Johannesburg, a GP with special interest in HIV.
Thank you. Thank you so much, Susan. Hi.
Hi. Next, I have my colleague, Gus Cairns, editor at NAM, who's worked in HIV for many, many years. He's also the coordinator of PrEP in Europe, and he's been living with HIV since 1985.
That's me. Hello, folks.
Hi. Next, we have Dr. Laura Waters from Mortimer Market Centre, HIV consultant there, and also chair of the British HIV Association.
Hi, thanks, Susan, and hi, everyone.
Hi. And finally, we have Josh, communications officer at the British HIV Association and trustee of the Sophia Forum.
Good to be here. And I'm the one that's actually had COVID-19.
Wonderful. Well, not wonderful, but I'm glad. I'm glad that you're here to share your experiences, Joe. Everyone who's joining us from Facebook and Twitter, please get your questions over. My colleague, Matthew Hodson, Executive Director of NAM, for once, is on silent. But he's going to be taking your questions and sending them over to me. So please get your questions over. So he's sending me messages and he says he's shaking a fist. So
I'll do it for him.
So I'm going to start off with you, Joe. Could you tell us what COVID-19 actually is and what is it like to have it as someone living with HIV?
Well, it's a virus. It's one of a family of viruses, most of which can be pretty much harmless. The common cold is one of the coronaviruses, so not that much that you would worry about. But this one is a new strain, and we didn't know it existed. We, as in humans, didn't know it existed. And as somebody with HIV, I'll be honest, I mean, it's scary because you may know that you're okay, you're on treatment, and as far as you know, your immune system is doing just great, it's fine and dandy. But there's a little bit of you that is going to worry like mad. And it isn't that easy to be rational when you have a temperature of 102 in old money, so as to speak. But one of the reasons I wanted to be here is just to tell people that you do get past it, you do get over it. You don't need to be severely ill. I mean, I don't have comorbidities or other illnesses, but I have seen 50. In fact, quite a while ago. I may even have seen more than that, but let's not go there. In other words, I'm part of a group that is thought to be more at risk, but I'm okay.
Okay. Great. And we've just had a question from Pedro. Are there any statistics focusing on COVID-19 patients with HIV or on heart treatment?
I don't think there's anything available at the moment because it is it's so new and this is so early days. Obviously, there will be attempts made by BEVA, by other authorities all over the world, to collect information on people with HIV who have COVID-19, but it's a bit soon to really be going into that.
Right. Okay. Thank you, Joe. And Laura, what do we actually know about how COVID-19 affects people living with HIV?
Well, as Joe says, we don't have that data yet. There's certainly been no signals so far that people living with HIV are at a higher risk of acquiring coronavirus or developing COVID-19, particularly severe COVID-19. If we look at the UK guidance, people with HIV aren't considered to be extremely vulnerable. There's a list of people with certain conditions and on certain medications who are advised to shield and really lock down for the next 12 weeks. And people with HIV are not on that list. Certainly the British HIV Association and EACS, the European AIDS Clinical Society, have said anyone with an undetectable viral load and a CD4 count of 200 is very likely to be the same as the general population. So they'll be at the same risk as people of a similar age with similar comorbidities. Beaver and Terence Higgins Trusts have said it's sensible to say to people with a CD4 count less than 50, or people who've had an opportunistic illness because of a suppressed immune system secondary to HIV, that they'd be sensible to follow the shielding precautions. But that's based on best guess. And like I say, there's been no signals emerging yet that people with HIV are at greater risk.
And what about people who haven't had their CD4 count taken recently?
Well, is this for me? Sorry. So we don't actually measure CD4 count as often as we used to. That's certainly true in the UK and true across the globe, I'm sure. Because what we know is once your CD4 count has normalized and your viral load is undetectable, as long as you stay on treatment with an undetectable virus, your CD4 count is unlikely to change. It will fluctuate to a degree, much as anybody's CD4 count will fluctuate, because your immune cells fluctuate depending on the time of day, if you've had another infection, and all sorts of factors. So as long as you've had a CD4 count that's reasonable at some stage and you're still on treatment and undetectable, you can carry that CD4 count forward, even if it was several years ago.
Right, okay, thank you, Laura. I just had another question coming through from Wade, who asks if ARV treatment offers any kind of protection for people living with HIV against COVID-19. Gus?
Yeah, I mean, fundamentally, no. PrEP will not work against COVID. They're different viruses. You may have heard that some of the HIV drugs are in early trials to see if they work against COVID, and so are a lot of other drugs. But frankly, we're at the moment at the stage of sort of throwing them against the wall and seeing if any of them stick, as it were. We need randomized controlled trials to find out if there are drugs we currently have in the on our books that will work against the virus. So there's no really definite indication that any of the drugs they've tried yet have a clear activity against COVID. And no PrEP won't stop you catching it, I'm afraid.
Okay, right, thank you. And Sindi, I have a question for you. I mean, what's the situation in South Africa? I mean, how many people are currently affected by COVID-19 there?
So the latest reports, just before we came on air, is 1,170 people. So we've seen quite a rapid rise in the numbers. And I think as more tests are carried out, the numbers are still going to rise. We've had 2 deaths. So our first deaths were reported today. And the country is currently on a 21-day lockdown. So we're trying to curb the spread of COVID-19. But difficult when you look at the socio-demographics and socioeconomics of our country. So it's going to be a challenge over the next week just to fix all of that and sort all of those things out. But we're hoping to flatten the curve in the next 3 weeks.
Right. And what advice would you give to people living with HIV in your region who are concerned about COVID-19?
I think, as Laura says, the most important thing is for you to be on treatment and to have an undetectable viral load. So at the moment, I'm encouraging people who don't know their statuses or who haven't started treatment to consider going for an HIV test. And if you haven't started treatment, please start treatment as soon as you can, and then let's get your viral load undetectable and make sure that that you're healthy. Because it's still coming. I mean, in South Africa, we can see it's coming. We have time to act, and we've got lessons from your countries and other countries as well. So there is time for us to act before it gets out of hand.
Okay, thank you, Sindi. And Gus, you're a member of the European AIDS Treatment Group, EATG, who've recently released a statement about COVID-19. What are some of the concerns that have been raised, and how is it affecting Europe?
Yes, well, I mean, to just repeat the point that people with HIV aren't at any more risk just because they have HIV. But of course, there's two things that EHG is particularly concerned about. One is that, of course, a lot of people with HIV do have co-infections, and a lot of us are over 50, including me. I'm 64, and therefore, as it were, in the vulnerable group. So that's one concern. The other concern is overstretched health systems. I mean, we have one of the best, for all its faults, we have one of the best health systems in the world here in the UK, and we're worried about whether we're going to be able to cope. So the obvious implications for countries that have poorer and more overstretched health systems are there, and they will have to manage things in a very different way. And then, of course, obviously in poorer countries, not everyone can self-isolate. If you live in a couple of rooms with your family, how are you supposed to self-isolate? So people will have to have very different solutions in some of those countries. Lastly, there are a lot of people with HIV who are vulnerable because of the kind of people that they are. HIV is more prevalent if you're homeless, if you're a drug user, if you're a sex worker, if you're a migrant, and also, actually, I should say, if you have a situation where you're exposed to domestic violence. And so all of those, I think, we mustn't let the services to those people who are very vulnerable wither away simply because we're concentrating on COVID. Those people are going to need our support more.
Thank you. I mean, I've had a message from Jason Domino, who said that sex workers in the UK can access help from the SWARM Sex Workers Hardship Fund. But I have another question. What if someone's asked if they're on treatment but with a naive infection, so still not with an undetectable viral load? Would one of you like to take that?
It's tricky, of course. We don't have data on people with HIV, and in most countries, most people with HIV are on treatment. Of course, there are people who are known as elite controllers who have got very good CD4 counts and either undetectable or very low viral loads. My advice, I mean, generally it's not clear, but most guidelines would say that even those people should be on treatment, because although risk is very different to when you have a low CD4 count, you're probably still at higher risk of long-term conditions because there's a bit more inflammation going on in the body. So my advice would be to start treatment, but absolutely to not panic. You are unlikely to be at higher risk, but I think for other reasons as well, even if your viral load is very low or undetectable on treatment, I would still recommend starting HIV therapy.
I mean, one of the concerns people have been raising is what should they do to ensure that they have an adequate amount of treatment?
I mean, obviously, taking this from a UK perspective, it's really difficult. It's a bit like the supermarket shopping phenomenon that of course, people worry about things running out. The advice is clear. You should have at least 30 days of meds at home. And if you've got that, don't worry. No one's going to run out of medication. No one's going to let you run out of medication, even if it's me on the back of my colleague's motorbike delivering it. There are really good systems in place, and the NHS really does do an amazing job across all disease areas of making sure that those sometimes fragile supplies are always maintained, and we don't even know sometimes there have been shortages because it doesn't actually affect the front line. I think the clear thing is to try to not panic, because where people have got extra supplies and understandably come in early, it's created quite a lot of havoc for pharmacies. Again, it's a testament to our health system that we haven't run out and people are getting their medications. But the main message is don't panic. Make sure you have at least 30 days. And if you're somebody who's shielding and you can't leave the house and there's nobody who can get the medication to you and you're not having it delivered, then it's sensible to make sure you've got enough for at least 12 weeks, because that's what the guidance is saying to expect if you fall into that group.
Thank you. And what would you say, Sindi, in relation to South Africa and people's concerns they have about getting having adequate amounts of treatment?
Okay, so in our country, people access treatment through the private sector, which is medical insurance, or you pay cash, or you access treatment through the government, and that's free of charge. So we know with the government that if patients have an undetectable viral load, they get 3 months supply. So they get 3 months supply, and they can take that home. In the private sector, you get monthly treatment. But we're trying to push for the medical insurers to give treatment for 6 months, just in case we run into problems. I don't anticipate us running into any problems over the next few months, because the pharmacies are regarded as essential services, so they'll be functioning throughout the lockdown. And even if the lockdown is extended, these services will still be running. So I don't anticipate any problems in the next few weeks.
Okay, great, thank you. I've had a question from Laswana, who asks if any of the panel are aware of a Barts University College London study called Healthcare Workers Biosource and Preliminary Analysis. Is that something that you've heard of, Laura?
I have. I don't know much of the details, but essentially this is a study. It's taking place, I think, at 3 different centres across London. And what they're going to be doing is, as far as I understand it, measuring antibodies in healthcare workers. So it's really going to get us some better understanding for people who don't have the antibodies, so haven't been exposed, following them up over time and seeing at what stage they get antibodies, how that correlates with symptoms. And it's going to teach us a bit more, because there hasn't been much widespread testing beyond people who've been admitted to hospital for the actual virus. So looking at the blood tests to see when people have been exposed will just help us understand how it's transmitted and what the risks to healthcare workers really are.
Okay, brilliant. And also, I mean, someone's asking about sources of information about HIV and COVID, and what digital support services can we access?
Could I answer part of that? There is now a group of more than 30 community organisations who are sharing information to make sure that everybody is consistent, which is really important. And so the way it's working is that, if you like, the basis could be the clinical information, the Q&A, the statements that are going up on the Beaver website, and they're being updated as soon as there is new and confirmed and clear information. But all of those community organisations have their own helplines. For example, there is Positively UK, there is THT, there is Positive East, there's Plus Health, who are doing an amazingly good job in Scotland. There is HIV Scotland, Waverley Care. So get in touch with your normal, if you like, or the nearest support organisation you would normally deal with, and they'll be able to give you specific information. If they can't answer, then believe me, because this is what's been happening, they'll come back to the central resource, or they'll come back to me, and we'll find answers for you.
Okay, great, thank you. I've got a question from Rebecca. She says, I'm also living with HIV and over 60, and my concerns are the severe isolation, as I really am a people's person. I'm finding it so difficult. I do know Rebecca very well, and I do know what a people's person she actually is. So do the panel have any advice for the social isolation that lots of people are feeling at the moment?
Well, I think it's all going to go virtual. A little illustration. I belong to a gay choir, and we've stopped having rehearsals together, but we had a virtual rehearsal last night. I'm wearing their T-shirts. I promised I would. Technically, there were a few glitches. Trying to get 30 people to sing in time with each other over the internet is quite challenging, but it was wonderful. Just the experience of all of us giving sound to our voices all at once over the net was fantastic. Now, there's lots and lots of mutual aid COVID groups springing up. We just had I literally had a flyer through the door today from my local one. And also, if you belong to a very specific group, then set up something virtual with the people you know. We are going to find out how much support we can get over the net, and I think it's going to be considerable. You know, yes, we won't have necessarily the touch of another person, but we can certainly reach out to them over the screen.
Okay, great. Well, has anyone else discovered the app House Party?
Oh yes, there's the House Party app, there's Zoom, all sorts. But one thing I want to make a plug for is the NHS volunteer scheme. because you don't have to leave the house. My mum is she's not going to forgive me this. Mum's 78. She didn't look it, and she's joined because she can be a volunteer from home and support people on the telephone. And Rebecca, I know Rebecca as well, and whoever gets you on the end of the line is going to be a lucky person indeed. And there are loads of schemes and virtual pubs. There's pub quizzes. There's live streamed gigs via Facebook. I mean, there's so much going on. But please, Rebecca, sign up for the NHS volunteer thing because I think you'd be amazing.
Okay, brilliant.
And I think another important thing to say, Susan, sorry to jump in, is that there's so much information that we're consuming about the coronavirus, but some part of the day has to be you focusing on something else, or else it gets very overwhelming and you feel very very despondent. So it's important for people to take breaks. I mean, I'm currently taking 3-hour breaks where I just shut off of everything and I focus on something else, whether it's shoes or bags or food, just to get my mind off the virus. So it's important for all of us to have some time out of the day where we're thinking about something else.
Yeah, that's wonderful. Thank you very much, Cindy. I have a question from Paul Clift in London. Hi, Paul. 12-week supply of home of ARVs is fine and possible. Not so possible, though, for other medications, such as for his asthma. What advice would you give in terms of getting hold of medications from your GP?
Yeah, I mean, obviously GPs are up against it, but they are still providing services. They might be telephone only, but those usual mechanisms, again, the pharmacies are running. Nobody's going to let people run out of medications. It's about making sure that you stay in touch with your GP, use the mechanisms that are in place. And ask. I mean, I don't know whether GPs are giving longer prescriptions at this time, but I think the usual mechanisms are still working. Just because you're not seeing someone face to face, it doesn't mean you won't get your usual care.
Okay, thank you. And a message from Roger from NAM. Now that coronavirus has been present for several weeks in Western European countries, how soon do we expect to see data on comorbidities in people with severe coronavirus? So far, the data have mostly come from China.
A long time yet would be my answer. I think the difficulty is that it takes a long time to recover from any kind of lung infection. And we know that it can take months for x-rays to normalize. It can take months for you to recover from the symptoms. So I think it's going to be 6 to 12 months and some before we really know. And if people are going to end up with kind of longer term lung conditions, it's going to be several years before we truly understand that. But I think sort of 6 to 12 months we'll start getting an idea of how long it takes for some of the x-ray and scan changes to improve.
Right. Okay. Anyone else have anything to add with that? Okay. A question that's come from Simon. He's been fighting to get his PIP reinstated. The assessment service says they might require face-to-face assessment. Is it safe for him to attend another one of those?
Shall I take this? It's
yes.
UK focus, isn't it? So Simon, sorry to do that. I think if they're asking for a face-to-face assessment, it's completely reasonable to push back and say, what's going on and is that absolutely essential? But if they are insisting you attend, then you need to follow the advice. If you're not in the group that's shielding, in which case, no, you cannot go. But if you're not in the shielding group, then you'd follow the same advice as if you're popping out to the supermarket or going for your once-a-day exercise, keeping appropriate distance, following all the usual hygiene tips, washing your hands regularly, and whoever does your assessment, make sure you stay 2 meters away from them. But I would hope in the current climate that they would accept that a virtual assessment would be entirely acceptable in these circumstances. So push back.
Thank you, Laura. And a question from Wade. He's never had a flu vaccination before. Is it still a good idea to get vaccinated during this period? So Cindy, Laura?
I'd definitely get it.
Yeah.
I'd get it.
Yeah,
Laura.
Okay.
Yeah, it's challenging. I mean, certainly because we're kind of coming to the end of the season, and my advice would be if you can get it, get it. Of course, the challenge is going to be getting it when GPs and other sites are very busy. But certainly, and I've heard mixed advice from people, but I would err on the side. I agree with Cindy of getting it if you can.
Okay, and there's a question that came in before. What's the position of people who've likely had COVID-19? When can they be tested for antibodies, and are they able to catch it again? So, doctors.
I can make a stab at this, certainly. So of course the antibody test is what everybody wants, because the antibody test will tell you if you've already had it, and it means people who are isolating because of a household contact who's symptomatic, actually, if they know they've had it, then there's no need to necessarily do that. The question is quite how realistic it is we're going to have a reliable test very soon. I know the headlines are talking about the many tests the government have purchased. My understanding, talking to friends who know much more about this than me, is those tests haven't been validated properly yet. So we don't know how accurate they are. And it's going to be several weeks, or dare I say maybe a few months before they're rolled out routinely, in all likelihood. The other key thing, so that will tell you if you've been exposed. Whether it gives you immunity, we don't know. It's likely it'll give you short-term immunity, because we've not seen any proven cases of reinfection during this current pandemic yet. But other viruses in the corona family, you can get them again about a year later. So the answer is nobody knows. It can tell you if you've had it. It can't tell you if you're going to get it again at the moment, but it's going to be several weeks at least before it's routinely available.
Right, okay, thank you. Women with HIV are disproportionately affected by gender-based violence. A question from Sophie, who's asking about women who might be asked to isolate in an environment where they're not safe. What advice would you give?
Yeah, that's a difficult one. I mean, in South Africa, we've got lines, and we've got telephone lines and centers that women can get in touch with if they feel that their lives are in danger. We have a high rate of gender-based violence, so we wouldn't want women to be isolating under such circumstances. So if she can get help and be taken somewhere else that's safe, that's the best thing to do.
Yeah, I would say that the same, that if you're at risk in life and limb from gender-based violence or any other violence in the home, then that is an emergency, and it's still an emergency. And so don't let fear of the virus prevent you, or let your partner influence you into not seeking emergency help, because there will still be emergency departments and the police. Most hospitals, Sophie says, have independent domestic violence advisors who can help you. So the normal emergency services are still going to be operating.
Okay, thank you. Another question. What's the situation about children living with HIV and COVID-19?
You want me to take that?
Yes.
Again, I ain't a pediatrician, but I know the basics. So actually, children are doing pretty well, really, in that there aren't many or any reports that I've seen recently of younger children suffering severe disease. There have been some published series of children, all of whom have had mild to moderate disease. The key thing with young kids is they are more likely to have no symptoms. So there's a lot of ranging about how common is COVID-19 without symptoms, but certainly in children that does appear to be more common. Quite why I don't know if anybody really understands whether it's because children get exposed to much more coronaviruses from that family and get some sort of partial protection. I don't think anyone knows, but so far kids are doing much better adults with much less risk of severe disease.
Okay. Brilliant. And a question for you, Gus. Would you say that there are any parallels now to what it was like living with HIV in the early 90s and 80s?
It is extraordinary for those of us who lived through that initial health panic with HIV to be living through this as well, because there are obvious parallels. I mean, the denial people went into at first, I was one of them. I thought, well, it can't be that bad. And that was very much the same that people originally felt with HIV. And also people needing to sort of educate themselves in a hurry about kind of, yes, this is what really is going to happen, and not to be led astray by sort of false hopes by politicians who wish it were otherwise, all that sort of thing. And the other the other thing it has in common with HIV is a period where people are asymptomatic but infectious, and that's one of the reasons why we have the pandemic situation we do. On the other hand, of course, it's completely different because this is, as it were, an equal ops virus. It's affecting everybody whereas, of course, HIV affected very specific and usually very stigmatized populations with all the sort of amazing political action that grew out of that, actually. And the other thing, of course, is that COVID is compressed into a very short period of time, we hope. What happened in HIV took years. What's happening in COVID is taking weeks. And that's a huge difference in terms of society understanding that it has to gear up and it has to do what needs to be done in order to do, as it were, the safest X of this virus, which is to stay at home.
Yeah.
Yeah. And what would you say, Jo?
Well, I was actually in denial when I had it. I had it early days. It wasn't COVID then. It was coronavirus, and you only got it if you knew somebody from China or you just come back from somewhere in the Far East. That's what everybody was being told. And I was not happily, self-diagnosing as having really bad flu, maybe pneumonia. And some of my friends, one of whom happens to be hosting this show, got very worried about me and said that anytime, day or night, they would come. And that particular friend was using the voice that she uses with her children, because apparently I wasn't making very much sense at the time. And I mean, even after I'd been told it was what I had, I still absolutely didn't want to believe it. It took me a while to accept that that is what had happened. And just for the sake of people who haven't had it and maybe wonder what it's like, the thing that made it so different, that really stood out for me, and this is more hindsight than at the time, is the fact that there was like no mucus. I wasn't blowing my nose. And although it hurt really badly when I coughed, nothing at all was coming out. And you see on the symptom list, they say muscle pain, which, you know, I interpreted as like flu, aches and pains. Not at all. You're holding yourself to try not to cough. And the pain is, you know, your intercostal muscles over your ribs because of the convulsive coughing that you're doing. But 1 in 3 people are asymptomatic. So I can make educated guesses where I got it from, but I'll never know, and nor will most people.
Well, Elias from African Advocacy Foundation says that people are asking him, you know, they've had a fever, but they're just not sure if it's COVID-19 or not. What would you say to them?
Well, all I can say is what happened to me, and I'm not everybody, I'm one person. But it really hurt. Like, if you can see here, it hurt right at the top of my chest. It was ever so sore. And before I got the high temperature, I felt this sort of soreness, and I thought anybody would think I smoked. You know, I mean, it was that sort of feeling. Then the temperature came, then the coughing came, and then I just couldn't get enough air in my lungs. But I mean, it is very dramatically different to, well, anything that, you know, you've experienced before, unless you're one of the people who really is asymptomatic, who maybe doesn't even have a slight fever. And what is worrying, I was reading some research in the Lancet today, which was showing that a CT scan will pick up symptoms of COVID-19 before the individual concerned has a temperature, before they have anything whatsoever, and in people that remain unaware that they have actually suffering from it.
Okay. Thank you, Jo. I mean, and a question that I've been asked as well. Say somebody has a really awful cough, and they contact their GP and they say it's likely to be COVID-19. Suppose they have another, let's say, a chest infection, and it's something where they might ordinarily be given antibiotics, what can they do?
I mean, I think the best thing that they can do is I do think, again, that the government, the NHS, etc., are doing an amazing job with the information that they're sharing. So now there's a 111 symptom checker. Now, clearly, it's not going to be perfect. No tool is perfect. And if you feel really dreadful, really sick, you call for help or you go to an emergency department. But, you know, as Joe says, a lot of people are going to feel really rough. So you monitor your symptoms. I think if you're coughing up stuff that's green, for example, and you get chest infections before and you've had antibiotics before, it's completely reasonable to have antibiotics again. We also have to recognise that some people will have coronavirus infection and something else. So things should still be treated in the usual way. People who've got asthma or emphysema and conditions like that should still do what they might do usually, which might be increasing their steroid inhalers or even taking a course of steroid tablets. Although steroids may not be a treatment for COVID, they will still treat the underlying condition that could be made worse. So I think do all the things that you would normally, but accept that the symptoms are going to be quite miserable and can be quite severe, like flu.
Okay, thank you. And are there chances of drug resistance if people living with HIV are having treatment for COVID-19? Someone's asked.
So the answer there is if someone's already on HIV treatment, and let's say, I mean, we're not recommending the use of HIV drugs to treat COVID. We're recommending they be used in clinical trials. Now, there are some clinics country that are using lopinavir, ritonavir. The brand name's Kaletra. Is not a drug that we use generally for treatment in the UK, although there are some people who started it several years ago who remain on it. Now, if you're already on treatment and that is added in, then no. If you're not on treatment, it's added in, then it's very unlikely because it's only about a 10-day course that they would give. And it's highly likely to get drug resistance. The same if you're undiagnosed. There's a very small possibility. And of course, if you're coming into hospital sick with a severe chest infection, then most units recommend, or in fact, national guidelines recommend for everyone, but many units do routinely do HIV testing anyhow.
Anyway,
very small, but of course, it's a perfect opportunity to test people for HIV if they are undiagnosed.
Okay, brilliant. Thank you. And another question from Sophie. People are stigmatizing those with coronavirus. What can we do as a community to turn that around?
I mean, what I'd say is what I said before. This is an equal ops virus. Anyone can catch it. I mean, anyone at all. So there's nothing that you can actually, as it were, do to stop it happening other than taking the health precautions that have been recommended. So it's not your fault if you get coronavirus, you know. I've noticed really more that first there was a sort of a first wave, which I hope is ebbing a bit now, that the kind of people who might be thought to be coronavirus carriers were getting stigmatized, particularly Asian people. There was a bit of racism, certainly, against Asian people, and you do hear isolated cases of that. It's pure ignorance, of course, because actually Europe is now essentially the center of infections. So, I mean, just repeating that anybody can catch it. It's incredibly contagious, much more so than HIV. It doesn't depend on what you've been doing. And really, you know, if you are in a position where because you have to go out or meet people and you do catch it, it's not your fault. That's really about the only thing you can say.
Yeah. Okay. So yeah, sharing information is going to make all the difference. I think this is why we're on this platform, and that's how we're using our social media platforms as well, to make sure that people are always getting the correct information, and that will help chip away at the stigma around COVID.
Okay, wonderful. And someone has asked, are people living with HIV any more likely to be asymptomatic carriers?
I think the answer there is, again, we don't know. I think it's unlikely. And I think, again, this issue about asymptomatic carriers, the figures veer widely from one range to another as new studies come out. So at one point, you know, some studies say it's up to 30%. Then there was data from China saying it's actually 1 to 2%, and then slightly higher somewhere else. I think the key thing is you can't say someone's an asymptomatic carrier until you've followed them up long enough, because some of these people who test positive for the virus actually just haven't developed symptoms yet. And if you follow them up longer, you know, about sort of 70% plus do develop symptoms. So I think that's an important distinction that some of these people will develop symptoms eventually. Then there's some debate around if you don't have symptoms or if you have mild symptoms, are you less infectious than people who do have severe symptoms? And again, I don't think anyone knows. There are some studies suggesting lower virus if you have no or minimal symptoms. Other studies show no difference in the amount of virus, whatever your symptoms are. So again, we'll learn more over time.
This may also come from the idea that HIV drugs may confer some protection against coronavirus. And just to repeat again, there's no evidence that they do. Really, we're just trying to see if various antivirals work. There is almost no evidence as yet that's really sort of scientifically robust that certainly any HIV drugs do. We're at that very early stage and we don't have the evidence to suggest that.
Okay, thank you. And another question for you, Gus. What and for the rest of you, what's the situation with regards to a vaccine for coronavirus?
Well, the very wonderful Dr. Fauci, the man of endless patience who stands behind Donald Trump and actually gives us the science, and who, of course, is a veteran HIV researcher, has said he expects it to take at least 12 to 18 months, I'm afraid, before we have a vaccine. And I would concur with that, even if we find one that works, because vaccines take the time they take. You have to be incredibly careful with safety with vaccines. You have to test them in animals. You have to do safety tests on small groups of people. Then you test different kinds of vaccines on slightly bigger groups of people, and finally you do a big trial. They're trying to accelerate this process as much as they can, but it will take the time it takes, and I don't expect we'll have a vaccine in time for this wave, as it were, of coronavirus. If there is a second wave, we may have one by then. We don't know.
Okay, thank you. A question for you, Sindi. How well is the lockdown working in South Africa? It must be hard to comply, particularly in disadvantaged neighborhoods.
Well, it's still only day one, and as I said, the police and the army are out there making sure that people comply. It is challenging. I mean, if you think that there are people that get paid weekly wages and they only got paid yesterday, and they could only go shopping for their groceries today, we need to take all of those things into account. And also need to remember that a lot of essential workers, especially the menial workers, they need to use public transport to get to work. You know, and cleaners that work in hospitals need to get there using public transport, so we can't shut that down. And of course, social distancing is a challenge. So there's a lot of things that the leaders have to think about and adapt for our setting. So it's not that social distancing is going to look the same in South Africa as it looks in England, for example. So we need to just sit down and figure out how we're going to make everything work for everybody while trying to flatten the curve.
Okay. Thank you. And another question for you, Gus. People who aren't having sex at the moment because they're locked down, should they stay on PrEP?
Well, my answer is that if you're not having sex at the moment, there's no obligation to be on PrEP anyway. Whatever your situation is, yes. I mean, you can take it daily as a precaution because not everybody knows if they're going to be lucky enough to have sex that night. But it is perfectly okay to take PrEP on an intermittent basis. People do if they're going off of family holidays or sort of like kind of situations where they know they're not going to be having sex for a while. Some people do take PrEP intermittently, or in terms of like when they think they're going to be at risk. The advice we have from the study that we have of that is that if you haven't taken it for a while, is about being careful to restart it, and you take a double dose the day before you start, and you make sure you keep on taking it every day after that, as long as you are at risk, and you take it for 2 days after that. This applies to gay men. The advice for women might be that you need to start it for a longer period than that, maybe a week before you start taking a risk that might lead to HIV exposure again. But if you know you're not going to have sex for quite a long while, and I think quite a few of us are in that situation, then there's absolutely no reason why you shouldn't stop your PrEP for the period and restart it later. Any more to say on that, Laura or Sindi?
No, I agree with you. If you're sexually active, then you continue taking it, and if you're not, you can take a break until further notice.
Yeah, I agree. And also, I think it's another example of some great resources. I know HIV Scotland, and also, if not now imminently, BASH, the British Association of Sexual Health and HIV, have developed some tips about, you know, sex in the era of COVID and the things that you can do that are contactless.
Okay, brilliant. And what advice would you give to people to actually, what can they do to stop the spread of COVID-19 themselves, particularly if they're in a household and they think they might have it?
I think do as you're
told. I think okay.
Yeah, I mean, basically
hand washing. I think hand washing.
I agree.
All of you.
Sorry.
The hand washing thing is really important. It is really a really basic thing, but I mean, I think it's really, especially if you've been outside, especially if you've been in places where you may be mixing with other people. I had to do a Tesco's run this morning. It was lovely to see how patient people were standing in a long queue 2 meters apart. I wore for the first time ever in my life surgical gloves as I was pushing my trolley around. That's an idea. I couldn't get hold of a mask, but there you are. People were being incredibly considerate, and so this idea of like 2 meters between you and other people, I think, is really valid as well. It's going to be difficult if you're in a household where somebody specific needs to self-isolate, but as long as we pay attention to those very basic guidelines, that's basically what we can do.
Okay, does anyone have anything to add to that?
Well, I agree with Gus. I think let's stick to the basics. We know what the basics are now. And the most important thing is not to panic. I think when you start panicking, you start making mistakes. But if you're cool and calm and collected, you know, we can get through this.
Yeah.
I mean, there's a wonderful COVID mutual support organisation already set up in my bit of my borough. There are loads of them springing up everywhere, and they are doing things like doing shopping for older isolated people. But what you do is you stop at the garden gate, you put the shopping down, you have a chat down the path. You know, that's what people are doing, and there is some incredible examples of help going on out there.
No, absolutely.
Yeah. Okay, brilliant. And I'd like to ask all of you, what are you doing to stay well emotionally through this?
Can I start?
Each of you? Yes.
I think it's really important to get yourself involved in the sort of thing that Gus was just talking about, which is doing something for somebody else, you know? And as Sindi was saying, don't spend the entire time watching the bulletin, repeat what it said on the last bulletin with a couple of additions for one or other bit of society. If you just do anything, just do a little bit of shopping for someone, have a little yell to the person who lives 2 doors down, get in conversation. You can do phone support for people, you know? There's always something you can do. And if you do that, you're going to feel an awful lot more cheerful. I live on my own. So, you know, I speak from experience of that. I have managed to convince the man next door that this is actually not a plot with a man-made virus from a superpower wanting to control all of us. Now, that was an achievement that cheered me up no end.
Okay, fantastic. Sindi, what would you say? What are you personally? Well, I know it's just day one of the lockdown. What are you doing?
Well, so I'm still working. I'm still working. I'm an essential worker, so I still go to work. I'll still be seeing patients. But the logging out and just zoning out of Corona every day is important to me. And when I do log on, I try very hard to be a bit hopeful because I think people need hope. So the hashtag, certainly for next week on Twitter, my hashtag is going to be Corona Hope. We need to look forward to life after Corona. And I want people to start thinking about that. We're going to get through this, and what are you going to do differently once we're through this?
Yep. I would say try and put some structure into your day. If you're lucky enough to be able to work from home, and I can, then I'm doing a sort of a work day, basically 4 days a week. Probably better hours than I keep in the office, actually. But also taking time out. The other thing I love doing is gardening. We've got a nice garden here. So among my essential things that I bought at Tesco's today were some dahlias and the clematis plant, which I'm going to plant tomorrow. You know, anything that makes you feel, takes your mind off the self-isolation situation and the COVID situation is great. And that can be whatever whatever leisure activity that feels restorative you most like to do.
Mm-hmm. Laura.
No, I mean, like Cindy, I'm working hours that I haven't worked since I was much younger than I am now. I'm not going to the gym, but actually my jeans fit better than they did before. But my personal tips are Campari-based drinks within the government's recommended limits of food. And listening to Iceland's Eurovision entry on repeat. Iceland's Eurovision entry is one of the best songs ever written, and the video that goes with it is amazing. So those are my 2 top tips for cheering yourself up at any time of the day.
Fantastic, wonderful. I've got one last question. What will the coronavirus epidemic do to rates of HIV and STI diagnosis? Do you think it will have an impact?
That's an interesting one. I suspect that we may see a dip, you know. I mean, people are probably having less sex. So, but I think it'll take a long time before we see any evidence of that, and only in countries where they can and do self-isolate. So, but that's just a guess. I have no idea, really.
And I think the other thing, of course, is not only that, you know, social isolation and less sexual activity. There's also the fact that certainly in the UK, sexual health services are not going to be offering the same capacity of testing that they've done in the past. There are online options, of course, but undoubtedly testing will go down, so that's going to have an effect as well. So whether we see a rebound, I think someone's already come up with some kind of pun for all the babies that are going to be born, you know, from sex during this time. So yeah, the corona generation, I can't remember what they called it, but I think there will be less testing. It'll be really hard to know. But of course, sexual health services are still running. You still can get tested. You still can get treatment, particularly if you have symptoms. So if you do, get in touch with your local sexual health service for us.
Yeah, I think it's the after. We did see a spike in STIs after both the First World War and the Second World War, and this has been compared to a war. So I think it's the after period we will have to watch out for.
Okay, brilliant. And also, I just want to say a huge thank you to Laura and to Cindy and to everyone, all you healthcare professionals. I mean, I don't know, did you probably wouldn't have heard the clapping from London, Cindy, but we had a big clap. Households across the nation were giving a round of applause to the healthcare professionals. Did you hear it?
And cheering.
Yeah. Awesome. Did you hear it, Laura?
Sadly, I was on a particular stretch of my walk back from Hitchin station to my home, where it was one woman on her driveway, but she gave it some gusto. It was still very emotional, but I saw a lot of the clips online, and it was just fabulous. It was really, really heartening and lovely. So, Cindy, if you've not seen it, do have a look, because that applause is for you as well.
I'll absolutely.
Oh, thank you, and I'll definitely take a look.
Okay. All right, everyone. Well, thank you all so much for taking part. It's been incredible. You've been absolutely fantastic. I'd also like to thank my glamorous assistant, Matthew Hodson, who's kept the questions coming, and there's been no gym selfies popping up or anything. It's amazing. And a special big thank you to Andrew and to everyone at Disruptive Live for making this happen. You're absolute geniuses. So for everyone. A very big thank you to everyone. If you want any more information, please go on to the aidsmap website, where there's lots of information that you'll be able to get there. But this has just been fantastic, and thanks again, everyone. Bye-bye.
Thank you.
Thanks.
Bye.